about LGBTQ plus healthcare inequality. So it's things that affect young people who identify as either lesbian, gay, bisexual, transgender, queer, or anything else within that umbrella, which is kind of what I use the plus for. But I usually like to start these kind of healthcare inequalities things with a more general point about how inequalities arise in the first place, because actually, when people think about and when people try and focus on healthcare inequalities and tackling healthcare inequalities, it's really easy to kind of really narrow down and focus down on like a specific thing, which is great. But actually, if you try and change one thing and then change one more thing and then change one more thing, it's not always necessarily tackling the problem. The better way to tackle any kind of inequality is to do it at the root kind of the problem. And understanding how healthcare or how inequalities in general arise in the first place is kind of super important to when you're then thinking about how to tackle things and how to change things and how to improve things. So I use this slide as an example of just illustrating that point. So this is a crash test dummy. This is what car safety kind of mechanisms and safety kind of things are tested against, obviously. And the fact that I want to give you that goes with this is that women are far more likely to be seriously injured or die in road accidents than men. Okay. So that's a fact. Women are way more likely to be seriously injured or die in road accidents compared to men. And this has nothing to do with driving ability. This has nothing to do with any bad stereotypes or anything like that. The reason that women are much more likely to be seriously injured or killed in car accidents is because all the safety features on all cars are tested against one type of crash test dummy, which is this crash test dummy. And that is based, this dummy is modeled around the standard male body size, weight, and kind of fat and muscle distribution. So inside these crash test dummies, there's a skeleton, there's kind of things that represent muscle with the right density and the right weight. There's things that represent fat with the right density and weight. There's things that represent the internal organs, and everything is weighted and distributed in the right way to match a kind of standard male body, right? So all safety features, seatbelts, airbags, the shape of the chairs, the crumple zones, everything in a car or in a vehicle is tested against that. Which means that we just don't know if those safety features work on anyone who isn't a standard male-sized body. I'd like to think that that isn't a deliberate decision or a deliberate kind of choice. However, it misses off, obviously, most people obviously are not a standard male body size. So obviously there is an inequality created by not designing something with everyone in mind. And you can apply that, you can do this in anything. You can look at so many things. And if something is not designed with everybody in mind, you will inadvertently absolutely create a inequality there. And how significant that inequality is depends on what you're designing. So when we design healthcare services or anything to do with healthcare, unless we consider every single person that is involved, we will create healthcare inequalities. And then it's up to people who are interested to then try and fix them. But actually, unless we go back to the thing that we're trying to fix and the design and the setup and everything, we're not actually going to fix anything. This just in general is a really good book. I would highly recommend reading Invisible Women by Caroline Criado Perez. It talks about this whole idea of data bias and systemic inequalities, largely focused around inequalities affecting women, because everything is pretty much designed with men in as the kind of focus, and it creates so many it creates so many inequalities in general. but it's a really good way. On top of that, I mean, it's fascinating just in of itself, and this is where I got the crash test dummy thing from. But it's a really, really good illustration of how any kind of inequality affecting any kind of minority are created because of this kind of implicit data bias and this kind of planning and design bias, because all of the users of that thing that is being designed are not being considered. It's an amazing book, so I highly recommend getting this if you want to understand anything about inequalities. So let's talk about LGBT youth. So as I said, I can't see the chat box. I'm going to get people to shout out, so unmute yourselves and shout out. So this is my favorite fact in the world, and I've blanked out the answer, and I want folk to shout out what they think it might be. Now, there's multiple things that are correct, that are factually correct, and there's one that I'm looking for in particular. So teenage lesbians have higher rates of what compared to heterosexual girls? Well, higher risk of what compared to heterosexual girls?
Suicide.
Suicide, correct. Not the answer I'm looking for. Depression.
STDs.
Someone said depression, correct. Not the answer I'm looking for.
I said STDs.
STDs, correct. Not the answer I'm looking for. You can see a pattern with this, can't you?
Is
Orgasms?
it pregnancies?
What?
Is it pregnancies?
It is pregnancies. Excellent. I think someone said orgasms, which is the second time that someone has answered that answer that I've given that talk, this talk. So I love that answer. But yeah, pregnancies is the right answer. So you can spot a pattern there: depression, STDs, so many things are correct in this statement. But this is my favorite fact, right? So this is based off, I mean, it's an awful fact, but it's my favorite fact because it illustrates such an interesting point. So this is based off population scale data from New York State in America, and has been reproduced in the UK as well. So the data holds. And basically, I love this fact because it illustrates how we can create healthcare inequalities if we don't plan things properly. So teenage pregnancy rates, if we jump back 10, 15 years, were astronomically high. They were absolutely through the roof. They were the #1 kind of public health, almost emergency, I guess. I remember when I was at medical school, I remember the graphs of kind of like, you know, literally off the screen of kind of the rates of teenage pregnancies. And it was just kind of this totally unaddressed issue. And if you look at teenage pregnancy rates now, they have the graph has kind of plummeted. They have massively reduced, and that has been because so much money and so many resources have been put into tackling this problem. And it's multi-agency kind of work and multi-agency resources. So far better education in school, so far better kind of healthcare education, relationship education, sex education, whatever the version of that is in any kind of particular school, far better, and tons of money put into education side of things, but also at the same time tons of money put into and resources put into things like better access to emergency contraception, change in legislation around access to emergency contraception. So not necessarily needing parental permission, not necessarily needing kind of proof of address or ID, that kind of thing. So way easier and way more availability of emergency contraception, and also far better access to prophylactic contraception. So especially things like implants. There was a real big rise in the uptake of people using implant as a choice of contraception. And again, legislation changes and access changes into how easy it was to be able to have access to prophylactic contraception. So again, not necessarily needing parental permission, and changing how we assess competency and the ability to consent. So tons of resources, and they're just a few examples. Even things like free condom schemes. So the ability for boys to access free condoms, again, all of these things together had a massive effect on the overall rate of teenage pregnancy. However, because that was done in a very heteronormative way, and it was a presumption that boy has sex with girl, ends up in pregnancy. There we go. Let's tackle that. Actually, this group of lesbian and bisexual girls were left behind. So, thinking about sitting there in sex education or whatever at school, not necessarily thinking that this applies to you because that's your identity. So therefore, maybe not necessarily paying that much attention to it, or not necessarily even attending it in the first place. But actually then remembering that sexual identity and sexual behavior is not necessarily the same thing. And they don't always necessarily match up. Teenage lesbians are far less likely to have prophylactic contraception because, again, as an identity, not necessarily would not necessarily feel that was applicable to them. But again, sexual behavior is different to sexual identity often. And even the ability to access emergency contraception after an event, again, if it's incongruent with identity, then you're far less likely to be able to access these kind of resources. Coupled with that, there's a few other things like lesbian and bisexual girls far more likely to have alcohol on board at first sexual encounter, far more likely to succumb to issues around peer pressure, around identity, especially if they're not out, and also far more likely to be coerced into sex or to be sexually assaulted as well. So all of these things put together means that they've kind of stayed up here in terms of a risk rate, and the teenage pregnancy rate overall has kind of come down like this, and they've been left behind. So now this fact then rings true. And again, the system wasn't designed specifically to create that healthcare inequality, but because it's a heteronormative system, by which I mean we design things just thinking of straight cisgendered people, often white cisgendered straight people as well. So we'll talk about multiple minorities later. We end up creating these kind of inequalities. So with that in mind, let's take a little run through a few things. So when I think about LGBTQ youth and their inequalities, I often find it really helpful to think about where they're coming from. If I'm sitting in the emergency department, actually, that snapshot of that patient in front of me, it's way better to try and appreciate where they've come from and their kind of life as a whole, rather than just the kind of healthcare setting version of their life, right? So we know that lesbian, gay, bisexual, and trans people face inequalities in accessing healthcare and experiences of healthcare. So lots of negative experiences of healthcare and suboptimal experiences of healthcare once they are in a healthcare system. But actually, even the accessing of healthcare can be affected. So LGBT people, for example, are more likely to attend an emergency department or like an urgent care center type setting compared to going to their GP or their family doctor for a general healthcare problem, which is largely based around the perception that they might be discriminated against, or the fact that it's kind of, going to your GP or your family doctor is a relatively intimate experience. It's one person and one person in a room. That can be quite intimidating, especially if there's a concern that there might be any kind of aspect of discrimination, even if the healthcare issue has absolutely nothing to do with that person's sexual identity or sexual behavior or anything like that. Compared to an emergency department, which is way more kind of anonymous and open, but it doesn't necessarily mean that the right healthcare is being accessed, and it's not necessarily the best place for someone to access the right things. We know that these inequalities apply to young LGBT people as well, and also LGBT parents of any child. So we don't have to necessarily just focus on LGBT youth themselves, because actually there are same-sex parents, there are transgender parents that also experience the inequalities in access and in experience of healthcare and healthcare settings. Coupled with that, most staff don't believe that sexual orientation or gender identity are relevant to healthcare. I'm here to show you that they are relevant. And whenever I do this kind of teaching, especially, in this setting, you know, you have all attended a session that is specifically about this, and you've chosen to attend it. So in a way, it's kind of preaching to the choir a little bit. But, you know, when I do this kind of session in the hospital to people that, you know, in a kind of general teaching session or something like that, to people who don't necessarily choose to be there, they kind of have to be there because it's on their teaching program, right? Then it's sometimes quite hard to convince people that this stuff is important. You know, I don't think I'm going to have too much of trouble convincing you guys that it's important because you've chosen to be here and you know what the topic is. But sometimes it is really difficult because people just say, this is irrelevant to my practice. I'm like, well, no, it's not. And even, you know, I had a neonatologist say to me, this is irrelevant because I only deal with babies. I'm like, no, you deal with parents. Like, obviously it's relevant, you know, and it is really hard to convince people. So let's take a little walk through where some of our young people are coming from. Okay, so I know I've spoken about parents, but I'm going to focus on young people for most of this. So let's look at school. So obviously this is sort of UK centric in terms of my facts and figures, but your homework is going to be to regionalize it. But I imagine that it rings true in most places. So the vast majority of pupils in school hear homophobic, biphobic, or transphobic remarks on a daily basis in school, right? And that can be little things like, oh, that's so gay, or, you know, that kind of thing, right? But actually, when you count up the number of times that that happens, the average number of times that pupils hear it, a homophobic or biphobic, transphobic remark on a daily basis is 25 times a day, right? So if you multiply that up over a 5, 6, 7 year school career, that's a lot of negative remarks, right? And it chips away. I like to have this kind of image of it chipping away at someone's armor. I don't really like the word resilience because it implies that it's the person's fault and they have to be resilient against something. But that idea of all of these little things adding together, chipping away at someone will have an effect, right? One of the biggest issues, I know we talked about education and sex education and things like that, but one of the biggest issues is that just LGBT kind of identities, issues, anything, it's just not taught at all or not covered in schools, right? Scotland has just very recently, Scotland has just announced that LGBT identities and issues are going to be mandatory on the school curriculum, which is amazing. I think we're the first country in the world that is doing that, you know, but it's 2021, right? Like, how's it taken this long? When I was in third year of high school, it was still illegal to talk about it, for a teacher to even talk about LGBT things. It was literally illegal. And I'm not that old. So, you know, we're making progress, but by and large, LGBT stuff is just not covered in schools. And actually, sometimes when it's covered, LGBT issues are talked about, they're addressed in a negative way, okay? And it's portrayed as a bad thing. Probably not at this school in the picture, because this would be an amazing school to go to. However, in some places it is addressed as purely as a negative. And even if it's not deliberately addressed as a negative, actually some people's report that they're just given inaccurate information, and actually their teachers that are giving them this information and covering these issues in classes are getting it wrong, and they're not telling them correct things. And they come out with, you know, things like saying lesbians can't get STDs. You know, well, they can. They get them more. So either things are not being covered, they're being covered negatively, or they're just inaccurate or wrong, okay? So young people are having to find this information out themselves, which A, is hard work, and B, is, you know, not necessarily the safest thing. And actually, we know that this has an impact. So we know that it should be pretty obvious actually to guess this, but we know that in places where LGBT issues aren't covered, or they're covered in a negative light, there's way more bullying. I mean, it's pretty obvious, right? But issues around homophobic, biphobic, and transphobic bullying are higher. There's also loads of interesting stats around. There's more in areas where LGBT things are covered negatively or not covered at all. There's more issues with problem drinking and binge drinking amongst young people, regardless of their identity. So young straight people have higher rates of binge drinking and problematic drinking if they live in a region where the schools cover LGBT issues in a negative or non-existent way, which is a reflection on kind of just really interesting sociological kind of things, right? Fascinating. Not got enough time to cover it now, but really interesting. So we talked a little bit about bullying. Over half of young LGBT people are bullied, experience homophobic or biphobic bullying in school. For trans young people, it's worse. So this is the better of the numbers. And consequently, about half of, or just over half of young lesbian, gay, bisexual peoples don't feel they've got an adult at school to talk to. And again, for trans young people, the number is even higher. The issue with them not having someone to talk to at school is, especially if they've also not got someone they can talk to at home, is when they access a healthcare setting, that is probably one of the only environments where they may be alone with an adult professional. And that adult professional might be the only person they feel they can talk to about their identity or ask questions to or raise any kind of issues. We might be in a position where we are the only person that they might be able to talk to. And if we are ignorant of some of the issues or ignorant of some of the facts, then we are going to be failing them, okay? And as I said, schools are not necessarily covering things in the first place, or they're covering them negatively or inaccurately. And even in the libraries or on the school computers, the school networks, a lot of LGBT resources are blocked. Okay, so schools sign up to, these kind of companies that offer web filters for, versions of parental control kind of things, safety filters. And a vast majority of these kind of filter services automatically block any kind of LGBT resources because they might mention the word sex or sexual or anything like that, or just because it's a deliberate choice, which is even worse. So consequently, a fifth of lesbian, gay, bisexual pupils don't feel safe at school. And I think it's about half, if not 3/4, on the most recent thing I read, of trans and non-binary young people don't feel safe in school. And this is where they spend most of their life there at school. And if you're not feeling safe in that environment, that is going to have a negative effect. And again, the knock-on effect of this is massive rates of skipping school, massive truancy rates. And we know that skipping school has huge impact. It has massive impacts on education attainment, has massive impact on decisions about further education. And then we know that if you then track that across someone's life, that has massive impacts on socioeconomic status, healthcare, comorbidities, things like that, life expectancy even. So purely because of negative experiences in school, it can have long running effects. And it sounds silly to say that because it's so obvious, but it still happens and it still is a problem, and not a massive amount is being done to kind of address it. So, okay, if school isn't necessarily great, what about home? So where people spend the rest of their time. Again, time to shout out. Does anyone know where this building is? Or does anyone want to have a guess?
Is it the one opposite the very, very homophobic church somewhere in the States?
Absolutely. A zillion points to you. So this is opposite the Westboro Baptist Church in America, which is that kind of just awful hate church that hold up those kind of God hates fags signs and protest people's funerals and things. So the guy that lives in the house opposite just painted his whole house as a rainbow and now has it as like an open house kind of thing where people can come and hang out and just be wonderful opposite this hate church. And actually the family next door, next door was like a 9 or 10-year-old girl who did some fundraising and painted her house with the trans flag just to really hammer home the message that the church won't welcome there. So yeah, my absolute favorite buildings. So, however, I'm going to now give you a sad fact. This is a fact based out of the UK. I imagine it's the same in a lot of places. A quarter of young LGBTQ plus kids who come out to their parents are told to leave home. Now, that's not a kind of just like slam the door, get out. That is a get out of my home and don't come back in. Okay, more than a quarter of young people who come out to their parents end up homeless. They are told to leave home and they have to go and stay with whoever will take them. Unsurprisingly, then, LGBT youth are massively overrepresented in the homeless youth population. So at least a quarter of all homeless young people identify as LGBT. Being homeless or unstably housed has its own healthcare inequalities that come with it and has its own impact on people's health and well-being. And there are huge risks with being homeless and unstably housed, especially as a young person. And you know that obviously that an element of that includes sleeping on streets and rough sleeping, but that also includes kind of sofa surfing and that kind of unstable housing situations. And the risks that kind of come with that, such as the provision of sex for food or sex for shelter or other kind of services, huge risks and hugely vulnerable young people in these situations. And yeah, just massively overrepresented in the homeless youth population. And actually in other places, so in America, 41% of the homeless population or the homeless youth population identify as LGBT. Massively overrepresented. You know, the population's like 10, 12, 15% max. Unfortunately, things are worse basically across the board for trans and non-binary young people. So half of trans and non-binary young people are abused at home, and that can include neglect, emotional abuse, physical abuse, sexual abuse. Half of young trans people and non-binary people are abused at home. And actually, you know, again, when I talk to healthcare professionals, I say, all right, how many people have looked after a trans or non-binary young person? And a lot of people have. How many have asked about their safety at home? None of them. Okay. And, you know, even if you've looked after 2 trans or non-binary young people, statistically, one of them has been abused at home. But we are not safety netting and we are not safeguarding properly because we just don't consider the inequalities and the just factors that are affecting young people's lives properly. And then just there's various other kind of risks that are worth thinking about when we talk to young people. So, for example, hookup apps and things like that. At least 1 in 10 young people under the age of 18 use kind of online hookup / dating apps. The number's probably more than 1 in 10. It's just underreported. And obviously, you know, there's risks that come with that, especially if we then jump back to the fact that there's poor education in school around inclusive sex education. So actually, if we don't deliver appropriate and inclusive sex education, and then we expect young people to navigate sexual activity via things like hookup apps, then obviously they are going to be at risk because they are not well enough informed. So if school isn't great and home isn't great, then what about hospitals? So again, UK based, but 3 in 4 staff have not received any training in the healthcare needs of young LGBT people. So congratulations to everyone here for not being one of the 3 in 4 now. And when I say, you know, the healthcare needs, it's the basic needs. It's what are the risk factors involved in their lives? What are the things that they need help with? What are the things that we can do to help them? This kind of stuff, right? The absolute bare minimum basics are not being delivered. At least 1 in 10, is that what that number says? My chat screen it says on my screen, I can only see 1 in something, whatever that says, 1 in something. Frontline staff have heard colleagues make homophobic remarks or biphobic remarks or transphobic remarks in a healthcare setting. And again, this is, this links back to that kind of healthcare inequalities in experience of healthcare, right? So navigating healthcare environments, navigating healthcare systems. If you are hearing staff make homophobic, biphobic, transphobic remarks, even if it's just, that one staff member over there, actually that gives you the impression, that's inexcusable anyway, it's not acceptable, but that gives you the impression that, okay, that is what the accepted standard is here. This isn't a safe environment for me or my family. Especially as people haven't got good training in how to, other staff haven't got good training in how to speak up in situations where they hear homophobic, biphobic, or transphobic remarks. So some of my students, I've got a kind of queer group of medical students in Edinburgh who have developed this amazing resource on tackling homophobia, biphobia, and transphobia in the workplace, in a healthcare environment, through active bystander training and kind of guiding people through different case scenarios, understanding what microaggressions are, things like that. And they're now starting to deliver that to healthcare professionals across our healthcare system. And it's really, really important because of this exact thing. If you hear a staff member make a homophobic, biphobic, or transphobic remark, and you also, which is bad enough in itself, but you also then see nobody stand up to it and nobody speak up to it, then you presume that that is the accepted standard. You presume that that is what is allowed in this environment. And therefore you presume that it is not a safe environment for you, which is going to affect how you feel there in the moment. It's going to cause distress in the moment, but it's also going to have an effect on whether you return to that environment. So it's going to have an effect on how you access. So it's having an effect on how you experience healthcare, but it's also going to have an effect on how you access healthcare in the future. When we think about adolescents as well, so adolescents by and large are a healthy bunch. Okay, so obviously the whole specialty of pediatrics, is a thing, but by and large, children are healthy, and most adolescents have not, in their living memory, really had to experience any kind of healthcare, and they've not really had to kind of navigate any kind of healthcare systems for any kind of substantial amount of time, because by and large they are healthy, and the things that happen to them are often quickly kind of dealt with. So when they are in a healthcare environment, it might be the first time that they are experiencing a healthcare environment, and if that experience includes witnessing some homophobia, some biphobia, some transphobia, that is going to be their impression of healthcare services, period. And that is going to affect, for the rest of their lives, potentially, how they access healthcare. And actually, I've been on this slide for ages, but there's so many points to talk about. Yes, we're talking about young LGBT people at the moment, but actually our older generation of LGBT people will have experienced these kind of things previously, and now that they are older might be having healthcare issues that do require accessing of healthcare services, but because of previous experiences of discrimination, it's going to affect how they access services. And we know that there's tons of healthcare inequalities that affect LGBTQ plus older people as well. So it's absolutely fascinating, this whole idea of how some negative experiences and perceptions can affect how people experience healthcare for the rest of their lives. Even worse than this, a proportion of people with direct responsibility for patient care have heard colleagues express beliefs that being LGBT can be cured, right? And actually in some areas, so for example, in London, the 1 in 5 people have heard a colleague in frontline healthcare express the belief that being LGBT can be cured, right? Obviously it can't, But this is worrying. This is concerning. Okay. So these kind of so-called gay cure or conversion therapies, it's been a hot topic in the UK in the last few weeks because the government years ago promised that they were going to ban conversion therapy and then didn't. They delayed, they stalled, they promised they were going to ban conversion therapy. I mean, it literally is torture in some instances, and it's certainly psychological abuse at the very least, and still didn't outlaw it. And then last week had a vote on it, didn't pass it, and then the entire LGBT advisory board for the government resigned, and then the government kind of went, oh shit, maybe we should do something now. Too little, too late. These kind of conversion therapies, gay cure therapies, whatever colloquialism you want to use, they exist and they are accessible, and they're awful. At least 51% of them are religion related, but again, half aren't. But some of them include exorcism, nausea, pain aversion, which is where you give people stuff that makes them sick when they are thinking or looking at anything LGBT related. And then you stop giving them stuff that makes them sick when they're not looking at things that are LGBT related. And the same with electric shocks. You give people electric shocks whilst they are looking at LGBT content. And then you stop giving them electric shocks when they're not. And the idea is that conditions one's brain. It doesn't, it's just torture. But these things literally exist and they are literally legal currently because our government are useless. Obviously, if anyone does come across this, it's a child protection matter, obviously, because we shouldn't be torturing children. This is a Scottish specific stat, but I'm sure that it holds true in a lot of places. As a consequence of some of these issues, only half of young LGBT people feel safe and supported in our healthcare system when it comes to their sexual orientation or gender identity. So it's not really good enough, is it? So I briefly want to touch on some of the effect of all of these inequalities. And this is where the kind of mental health kind of side comes in. So nearly half of all gay people who experience homophobic bullying have symptoms consistent with depression. This is the best number out of all of the identities. So lesbian, bisexual, transgender, non-binary, queer, young people all have even higher rates of depression. So 46% is the best rate and everything else is worse. So it's, what I'm saying is it's pretty bad. Interestingly, so even young people who haven't experienced any form of direct discrimination, they've not been bullied at all, still experience a far higher rate of depression and anxiety than their straight cisgender peers, right? I use gay young people here just to be consistent with the previous number, but again, the numbers are worse for the other identities. But this illustrates this idea that you don't have to actually experience any specific bullying or specific direct discrimination to suffer the effects of it. And this is something called this relates to something called the minority stress model or minority stress theory. Second bit of homework for you, go and look at the minority stress model. It's really, really, really interesting. And it doesn't just apply to LGBT youth. It applies to any minority, any age. And it's a fascinating kind of description of the process that happens that causes these kind of negative effects, right? So the minority stress model essentially says that if you are a member of a minority in the context of where you are, so the society or the environment that you are in currently, you have a physiological response to the added stress of being in a minority. And actually, when you then think about it, it does make sense. So even the perception that you might be discriminated against and therefore might not be safe and therefore have to constantly think about your safety at all times, or most times, that is enough over time to have a physical effect on your body. So there's a ton of cool studies that were done that measured like cortisol stress responses and various other kind of hormonal stress responses, and found that people who were members of minority groups had altered physiological responses similar to the levels that you would find in people with PTSD. And this held true even if people had literally never experienced an actual kind of episode of discrimination. It was purely the perception that they might experience something purely because they're a member of a minority. What also happened was, if you were a member of multiple minorities, so if you are queer and a person of color, or if you are queer and disabled, or if you're a person of color and disabled, any combination of any minority, it had a cumulative effect. So that physiological stress response, that chronic response, was multiplied with each minority group that you were a member of. Okay, and we'll look at that in a sec in some of the other outcomes. So over half of all young LGBT youth self-harm. And again, when I'm talking to pediatricians and especially emergency department physicians and clinicians, you know, obviously we see tons of young people who self-harm. We do not ask them about their identity. How are we going to address any of these kind of issues? How are we going to help young people properly if actually we're not understanding where the root of the problem is? We don't ask them, but yet we know that over half of all LGBT youth self-harm. And just here we go, here's an example of that multiple minorities effect. So if you are a person of color who is also queer, then all of those effects are worse. So for example, 83% of BAME young queer people will self-harm. So, you know, it's almost everyone that we see. Do we ask them about their identity? No, we don't. So 3/4 of young gay people have had thoughts of suicide. Again, this is the best number out of all of the identities, and it is worse for lesbian, bisexual, transgender, non-binary, and queer young people. Nearly 1/4 have tried to take their own life, and again, it's worse for all the other identities. And actually for trans young people, so again, this is a UK stat, because our care of young trans people is horrendous. It's almost non-existent. Half of young trans people have attempted suicide in the UK. I'm sure that the number is similar in a lot of places. But this is, I mean, this is an awful stat. Half of young people who are trans have attempted suicide. And the thing to know about this is that this is entirely avoidable. So in some parts of the United States, as many issues as their healthcare system has, and it has many, one of the benefits of the US healthcare system is in some states, actually, some of the services are just full of money and resources and actually work quite well if you can access them. However, it does mean that you can do some studies that you might not necessarily be able to do in other countries. So in the states that have good trans healthcare, they've done multiple studies that show that if a young person has timely access to supportive healthcare relating to their gender and have a supportive family, they end up more psychologically well-adjusted when they're in their 20s compared to the average population, the general population. More so they have lower rates of depression and anxiety and other mental health issues than the general population, and the suicide rate is 0%. It's like 0.1%, right? So this 48% of young trans people having attempted suicide is entirely avoidable. It can become 0% if they are given timely access to supportive healthcare and we get their family on board. And that is possible because it exists in other countries. Yet we let it carry on because we don't want to address these kind of issues. And then just a few other things, just to move away from that. So eating disorders are more prevalent, and disordered eating is more prevalent in LGBT youth, particularly so in trans young people, and to a degree non-binary young people as well, which is largely around control of body appearance, and also things like control of whether people have periods or not, for example, because GPs in particular are quite bad at knowing what or contraceptives to provide to try and get on top of periods for trans boys, for example. But also, if you look at lesbian and bisexual and gay and bisexual young people, for boys and girls, for cisgender boys and girls, there's higher rates of disordered eating as well. And again, some of it's related to control of body image, some of it's related to trying to conform to what they perceive should be a stereotype that they should conform to. And some of it is just the elevated mental health effects of, for example, as we talked about, the minority stress model. So in the last few minutes of the main bit, and then we can have a wee Q&A after, what kind of things can we do? Well, as I said right at the start, a lot of it is around actually addressing the sort of more systemic things, which as individuals, yeah, maybe we can do, but it's hard. But addressing the systemic and addressing the very root of the problem is really kind of the only way that we can address these kind of things. And that is multi-agency. That's better education. That's better access to healthcare. That's better access to other resources. It's better access to housing. It's better support for homeless populations. All of these things are what we need to do to try and improve things. But there are things that we can do individually as well as healthcare professionals. My main thing, because of those terrible stats and because they're having such a terrible time at the moment, is protecting trans young people. So if we can do anything, it's trying to look after our trans youth, because they're the ones that are suffering the absolute most. And actually, as individuals, it's quite easy to do. Using correct pronouns and being able to comfortably ask about pronouns as well. People get in a right state about how to ask things and how to respect pronouns properly, and get into such a worry that they're going to do it wrong that they then don't do it at all, which is just as bad. So it's better to kind of awkwardly ask and make a mistake or whatever in earnest than to not do it at all. But actually, the more we do it and the more we try, the easier it becomes, right? I was, before the pandemic, when we were able to actually go inside places, I was in a coffee shop, and there's a high school just down from where I live, and I was in a coffee shop around lunchtime, and all of the kids were in the coffee shop as well. And there was a table behind me of, they must have been like 13 or 14, right? They weren't old, of kids, and they were saying they a lot, and they were talking about someone saying they, just saying the same thing over and over and over again. And it kind of was like, I couldn't quite work out what they were doing. And then after I listened for a little while, it turns out that one of their friends had, one of their friends had come out as non-binary and had the pronouns they, them. And that person wasn't there, but their friends were practicing just over and over again so that muscle memory could come of just using they, them with that person's name so that they wouldn't misgender them. And they were just practicing, and it was so wonderful. And I like to try and use that as an example of, we might get things wrong if we are trying, but over time we will get this muscle memory of actually being able to use pronouns properly when we're asking about them. So I now have a system of, I introduce myself with my pronouns often, and I have a little badge that I sometimes wear. But when I'm talking to young people, when I go to see a patient, especially in the emergency department, I will try and just say, I'll introduce myself. I'll often introduce my pronouns, and then I will ask, what would you like me to call you? How would you like me to refer to you? Because actually, and that doesn't just apply to trans and non-binary young people, people have nicknames, people have shorter names that they want to use. So actually it benefits everyone. And then once someone tells me what they want to be referred to as, using that just consistently and just as much as possible, so that you then have it in your head, and then you won't misgender that young person. This also applies to being able to change hospital records as well. So especially with electronic records now, it's really easy to change someone's healthcare records. And people can, legislation will be different in different countries, but by and large, people should be able to consent to have their own healthcare records changed. And it doesn't matter about their age. So we changed, we had a 5-year-old ask for their pronoun to be changed on the healthcare record. And we just changed it because that's what they wanted. You know, it's fine. So using pronouns correctly is really important. Just a brief side note, there was a period of time where the phrase preferred pronoun and chosen name was used. We're trying to move away from that because it kind of invalidates it a little bit, this kind of idea of preferred. Pronouns just are someone's pronouns. So it's not that they prefer them, it's that that is their pronouns, right? And the kind of chosen name and things, actually, no, it's just that is their name. So we're trying to move a little bit away from the word preferred pronouns and the word chosen name, but you might still hear people kind of talking about that. But it's a little bit invalidating, so it should just be that is someone's pronouns, that is someone's name. Done, easy. And actually, we know that there's been some nice studies that show that simply using someone's name correctly and someone's pronouns correctly is suicide prevention. We will actively, we can all have a role in suicide prevention. We could all actively reduce the risk of someone committing suicide, attempting suicide, sorry, by using someone's name correctly and using someone's pronouns correctly. Okay, and actually, these studies have been done. Right, you'll see that actually they use chosen name in the title, which is why I mentioned that. So we've moved a little bit away from that, but that was what it was in the paper. And briefly, just because it was in the news, we've had a High Court ruling here, which has been disastrous, but there's a lot of controversy and things around puberty blockers, which is nonsense. These ideas of them not being safe and that kind of thing is nonsense. Using puberty blockers and as they are colloquially called, but you know, things that just delay puberty, literally reduces that suicide risk. And again, there's lots of stuff that's been written about it. But as individuals, especially as students, you know, what we can do is use names correctly and use pronouns correctly, and that will actively reduce suicide. Less easy as an individual to affect and less easy as a junior to affect, but as you get higher up in your career and as you have a little bit more agency in wherever you work, influencing environments is really important. So if you work in a place where it doesn't have large toilet built kind of rooms with, you know, multiple cubicles and urinals and whatever in, if you work in a place where the toilet is a room with a toilet in it and a door, and that is it, it's an individual toilet with an individual door, and on the sign of the door it just says male, and then there's another room that says female, there is absolutely no reason why they should be gendered toilets. There's no reason why anyone can't use that toilet. The only thing that makes a toilet gendered or not, and not an inclusive toilet, is whether there's a disposal bin for menstruation products, right? So that's the only thing technically that makes a toilet inclusive or not inclusive. So if you work in a place that has individual roomed toilets with a sign on the door and that sign is gendered, it does not need to be. And actually anyone can raise that as an issue, and anyone can try and push to have those things kind of changed. Right, so some places are starting to have this kind of all gender restroom, which actually, you know, is a kind of going a step further than you need to then come back to the fact that it's just a toilet, right? But it's kind of laboring the point to then create the equality and the equity eventually. And then last couple of minutes, the other kind of things we can do is just be visibly inclusive. So we can be visibly kind of visible of our identities, but also visible of our allyship. So I've got my little badge on here. There we go. Which is this badge that's in the photo. So across the NHS in England, we launched this rainbow badge. I haven't got time to kind of tell you all about the project. It was a cool project though. But basically the idea of this badge was, it's a visible sign that someone is a safe person to kind of talk to or be around. But also the badge came with a kind of information pack that talked about some of these healthcare inequalities that I've spoken about, that we developed, and it came, and you had to sign up for it. So you had to kind of pledge that you were going to be an ally and you were going to be a safe person that people could talk to. And you had to have some basic understanding of where to signpost people for support and resources and that kind of thing. And if you signed up to that, and if you took that leaflet and you read it and that kind of thing, then you were allowed to wear this badge. And we started off with like 100 badges, and then we had 300 badges, and we kind of sent them out to random people on Twitter. And we started getting really amazing stories back of literally like life-changing / life-saving stories of people, of patients being able to, especially young patients, being able to talk to a healthcare professional purely because they had this badge on showing that they were a safe person to talk to. So we took that and then we scaled it up and up and up. And this was done mainly by a guy called Mike Farker, who is a pediatrician in London and an incredible person. And now I think it's nearly like 500,000 badges across the UK, worn by healthcare professionals who have pledged that they will be safe and responsible people for LGBT patients. And we're just introducing, we're introducing one in Scotland, because this is the NHS England logo, which was not very welcome in Scotland. But we're making one in Scotland, which has got the progress flag on it. So it's got the trans flag colours, and it's got the black and brown stripes as well, with the NHS Scotland logo. So we're producing that. But it's a sign that individuals are safe and kind of welcoming people. So this was the kind of leaflet that it kind of came with, and people had to kind of sign up to it. And then lastly, actually, we can look at environments. So that's individuals within an environment, but we can also look at environments in general. So this is a picture of a notice board in a GP surgery, so a sort of primary care practice, where we made these posters which had some value statements on them and had some promises on them. And basically a environment, a clinic or surgery could display these in like the waiting room or in the corridor, or that kind of thing, if they had some sort of LGBT healthcare education. So we made these leaflets that you can see, and we had some education sessions. And if GP surgeries had some education and they'd done something proactive, they were allowed to display these posters. And again, it had huge impact on the patients that they served, and led to some really amazing stories of opening up communication and reducing healthcare inequalities purely from just having a visible thing. I'm going to skip through a few things. So we can advocate for patients, we can empower patients, and we can listen to patients. And as individuals, we can be visible, we can create safety, and we can create inclusivity purely by doing a few really simple things, but also by understanding where people are coming from and how those healthcare inequalities are created in the first place. So that is my little whistle-stop tour of things. I'm going to try and minimize my screen. Oh, no, I'm not going to do that. Stop share, and then I can come back to this. Has anyone got any questions? Let's do a quick Q&A thing. That was just a little bit over an hour, sorry. How do you want to do the question thing? Let me get the chat thing up. Shout out to organisms, yeah, great.
I've got a question.
Sure.
So how is your hospital with all of this, and like how was it before you came or after? Like how did you initiate something there, and if so, how did you start initiating something more pro LGBTQ in your hospital?
That's a really good question. So in general, so I've worked in quite a few hospitals, and in general, they are very open to the idea of change and very open to the idea of trying to make improvements. but they've just never really thought about it, right? So I've never experienced too many barriers to trying to get things changed or improved, but it's more that they've just never had anyone say, we should do this or we should do this. So often it's been trying to just convince people that they should do something. And as soon as you show them that there are problems, then they tend to then want to address them. So I've done it. I've done it a few ways. A lot of these healthcare inequalities affect adolescent patients. Obviously, you know, there's parents and that kind of thing, but a lot of them kind of are focused on adolescent people. So one of the ways that I kind of help to bring around some change is by really focusing on our adolescent services, and we have like a adolescent committee of different staff, and by joining that, I was able to kind of keep advocating for small changes, and also by addressing kind of wider kind of adolescent healthcare things. So we talk about adolescent history taking, and there's different models that you can use to structure your history taking for adolescents, and which has nothing to do with being LGBT, and it's nothing to do with these kind of healthcare inequalities, but you can talk about you know, how to ask about identity, how to ask about sort of sexual activity and that kind of thing. So sometimes I've kind of gone via a slightly different route to actually get the same result. And then one of the other things I've done is I've done this kind of talk, and I've either held events or kind of been a speaker at events where I've done this sort of thing, which is more about convincing people that it is a problem that needs to be changed. And then I've invited the important people to it. So I've invited, you know, like the hospital director or the public health director, and kind of dragged them along and kind of made them listen, basically. So it's largely been positive, but sometimes it's about kind of trying to really just drag people in to the right place to make them listen. Once they've listened, then it's relatively more straightforward to kind of try and get them to agree to change. I appreciate that is coming from largely from England and Scotland, where it's probably not as difficult as in some places. So I'm just going to read a couple of these questions here. Yes, so there's a question here from a Middle Eastern perspective, is how can we be supportive of patients when the wider healthcare system is hostile? That's a really good question. So I'm going to use an example from the UK healthcare system, which illustrates this point about how you can do as an individual, how you can safely support someone. So we talk about, for example, when you talk about pronoun use and using people's names correctly for trans and non-binary patients as an example, but actually this would apply for any LGBT patients. You know, we talk about always using the correct pronouns and always using the correct name, but that's coming from a point of view of presuming that everyone who knows that person knows their identity, right? But it's not always the case. So you could have a trans or non-binary patient who might not be out to their family, for example. So when their family are visiting in the hospital, it's not okay to use that person's correct name or pronouns because it's not safe for them, because then you'd be outing them. But actually, they know that, obviously. So as an individual, you can use that person's name correctly, and you can use that person's pronouns correctly when you are talking to them, and they know that, and you can say, but don't worry, tell me what you would like me to call you when your family are around, right? And that's a really safe way of supporting that person, but also being aware of the wider context. And actually, you can then extrapolate that if you've got a whole healthcare system that is hostile. For example, if your healthcare system is in the Middle East, as a one-to-one, you can still potentially support someone by respecting their identity and asking that and having that kind of open conversation with them, but also then say, what context do you want me to not use this terminology or this phrase or this pronoun, etc. So you can show allyship and you can show support between you and the patient without having to have that as a kind of wide open thing. It's harder, and you don't get to have the kind of visibility kind of thing and the rainbow badge and that kind of thing, but you can support an individual whilst respecting the fact that you can't do that in an open place, and it often has just as good an effect as doing it kind of openly, if that makes sense. Right, I'm going to read a few more. How do you recommend dealing with closeted youth who can't come out and separate themselves from their parents? Because how do you spotting that and responding? Oh yeah, okay, good question. So the question is, how do you help young people who aren't out to everyone or aren't out to family and friends? So it's very similar to what I was just saying there. If a young person comes out to you or they tell you that they're not out to a lot of people, or you get that kind of sense that that's what's going on, reminding them that they don't need to be out to everyone, that their identity is no less valid because they're not out to people, is really important. And even just if they are out to themselves, that is just as valid, and their identity is just as valid as if they're out to everyone. And even just reminding them that and telling them that and validating them yourself can have a really, really big effect. And telling them, hey, look, you don't have to come out to your family right now. You don't have to come out to whoever right now. That's okay. If you can signpost them to resources. There's some really great resources online of like how to come out safely and just the whole kind of coming out process. So you could always signpost them and say, hey, look, go and look at that at some point if you can. And if you're in an environment where that's safe to do so, or that's possible. But even just validating someone's identity and saying, look, you don't need to tell anyone. That's okay, can have a really good effect. Non-supportive co-workers. It depends on the environment you're in, how to deal with non-supportive co-workers. If you are in a country that has legislation that protects A, patients, and B, staff when it comes to their identity, so any kind of protected characteristics, then having a non-supportive worker, you can either go down the soft route of trying to educate and trying to bring them on board, or if it's a problem, if they're problematic in how unsupportive they are, you can go via reporting lines and you can just say, well, look, you're breaching legislation, so this is not acceptable. Obviously, again, that doesn't work if that legislation and protection doesn't exist, in which case that kind of education route, and kind of sometimes it does come from a place of them just being ignorant and saying, oh, actually, did you know that you shouldn't say that? Or have you thought about a better way of saying this? Or have you thought about the fact that this might be a problem? And doing it, kind of trying to show them the right path, which is hard. It's hard to do that. If you have a colleague who is supportive, then often doing that as a pair. So if you've got someone who is doing something wrong, but actually that you've got a colleague that actually is quite a good ally or is quite supportive of kind of any kind of identity things, you can kind of bring them along and kind of tackle it as a pair, and often it gives a little bit more validity and safety in that. And that goes for people making insensitive comments as well, just to address the next question. Do I have any good sources to recommend to educate ourselves more on what we as doctors can do to deliver better care to patients? Yes, I will send a list of things that can be emailed out. So I will send that across, and then you can all have something to look at. Is that okay for that one? Oh yeah, restructuring facility and workers, history taking system you spoke of. safe clinic. Is there anywhere all these resources are gathered? No, there's not. Hey, we should make a website where it's all in one place, shouldn't we? That's a good idea. No, but I will send a list of things. I'll send you a link to the work I did that I talked about with the GP practices, with those posters and those leaflets, because it was a really cool project where that was all hosted on one sort of site for the GP, for all the GPs, and it was particularly focused on rural practice. So in Scotland, we've got the Highlands and we've got the Islands, and often you can have one GP for an entire island of people. So it's super important that they are seen as a safe and accessible person, because they're the only bloody person there, right? Which is why we kind of did the work. So that is quite a good site that they created. So I'll send a few links, and I'll send a link to that site as well. Non-sporting patients when wearing the rainbow badge. Have I got any responses? Actually, no. I've never had a negative comment about the rainbow badge that I wear. I've had a few colleagues, as I said, like 500,000 people have got these badges now. There's been a few people asking about it, and they kind of go, oh, great. But they don't say a negative thing. The problem we've had recently is that in the UK, the NHS seemed to adopt the rainbow as a kind of pandemic symbol of the NHS. So the rainbow became a kind of NHS, just general, oh, look, aren't we great in the pandemic kind of thing. So now all these rainbow badges, people are like, oh, yeah, you're supporting the NHS. And it's like, no, I work for the NHS. This is LGBT stuff, but that message has been confused now. So sometimes we get people that just get the wrong idea, and you have to kind of tell them, which has been a bit of a problem. How do I suggest handling parents, families that are dismissive of it being a thing, these are cultural issues? Yeah, really good question. So sometimes you can't convince a generation that they're wrong, but you can. I had this the other day. I spent like 4 or 5 hours looking after a trans teenager in A&E in the emergency department, and their mum was quite supportive, but was clearly struggling, but clearly wanted to be better, right? They clearly wanted to support their son, who had only kind of been out as a trans boy for kind of four months or something, so not a long time. And they were trying, the mum was trying, but they were just clearly struggling. So I said to the young person, hey, what would you like me to tell your mum about? If I could help educate your mum, what would you like me to tell her? And they kind of gave me an answer. And so I took the mum to another room, and we kind of just talked about it. I was like, look, what are you worried about? What are the things you're struggling with? And we can kind of talk through them. And one of them was exactly this. She thought it was a kind of, it's just, it's popular now. It's what everyone's doing. All these online people are trans, and that's why my young person is trans. They want to fit in and be cool and be in this kind of like, yeah. And I kind of went, okay, look, I understand that, and I can see where that's come from, because it is way more talked about and visible. But the thing I said to her, which kind of she really resonated with, I mean, your son has tried to kill themselves 5 times in the last 5 months. If they were identifying as trans because it was just the popular thing at the moment, they wouldn't still be doing that after their 5th attempt at killing themselves. And I kind of just said it exactly like that, and then to kind of stop talking, and you could see that kind of process in her head. And she was like, oh shit, yeah, actually that makes a lot of sense. And sometimes it is just hammering home that kind of, no, this is the reality. It's not just this fad and this kind of cool thing. And even, you know, they're not necessarily just trans and non-binary identities, right? Even just lesbian, gay and bisexual identities and other queer identities, you know, reminding someone or educating someone about those significant effects, people wouldn't do it. People wouldn't be like, oh yeah, I'm gay because it's popular. Because why would they expose themselves to all of those negative effects if it was just a fad that they were going along with, right? And using that as the kind of education thing, and I'm putting that question back on the parent, really makes them kind of realize, oh, actually, yeah, I'm not seeing. They're seeing the expression of the young person, but they're not seeing the identity side of it and everything that comes with that. And trying to help them see that can be helpful. It doesn't always work. Are there any other questions? Oh, cool. That's a good story, right? Oh, that is a lovely story. Hey, we are here for the mums who are trying their best. That's really great. I like that a lot. Good story.